Okay, here's our agenda. We have 3 presenters today. Dr. Katzen will provide an introduction to intravascular robotics and discuss its current and future role in interventional procedures. Then Dr. Sterling will provide insights from starting up an intravascular robotics program at Inova Alexandria Hospital in Virginia. And finally, Dr. Bagla will review the current state of prostatic artery embolization and share how robotics may play a role in the development of this emerging and very promising procedure. Then we'll have the Q&A period at the end with all of our presenters. Our first presenter is Dr. Barry Katzen. Dr. Katzen is the founder and medical director of Miami Cardiac and Vascular Institute in Miami, Florida. Dr. Katzen has been a leader in the development of interventional radiology and multidisciplinary models for delivering cardiovascular care. He was awarded the Gold Medal for Lifetime Achievement by the Society of Interventional Radiology and was the first American to receive the Gold Medal from the Cardiovascular and Interventional Radiological Society of Europe, or CIRSE. Throughout his career, Dr. Katzen has been a leader in the development of new, less invasive procedures for the treatment of vascular disease. He and his colleagues at MCVI have been pioneers in the clinical use of intravascular robotics. Dr. Katzen is currently a lead investigator on the ROVER Registry, which is a post-market, multi-center study of clinical procedures performed globally with the Magellan Robotic System. Thanks for joining us today, Dr. Katzen, and I will now turn it over to you.
Thank you very much, Brian, and good afternoon. Good afternoon, everyone. It's a pleasure for me to participate in this panel and share some of our experience and thoughts about intravascular robotics. If we can go to the next slide, please. And just by way of disclosure, I think you had a chance to look at that. Or, sorry, thank you. Next, please. So we became interested in vascular robotics, looking at the increasing importance of robotics in healthcare in general, and looked at the potential of robotics as bringing about reduced radiation exposure to patients, operators, and staff, perhaps providing improved precision, and reducing the degree of vascular trauma associated with manual catheterization. It's a possible solution for those of us involved in medical education and training physicians of multiple disciplines who have less foundational training experience, and also has the potential to facilitate more complex procedures for operators who are missing this foundation. As we go to the next slide, we begin to see some of the components of the Magellan Robotic System. On your left is the arm, the robotic arm that stays on the patient's table side, and to your right is the actual remote physician console. This can be coordinated at both the remotely and the table side. And in this animation, you can see at first the robotic remote animation, and this is the robotic arm on the table involving the components that allow us to steer the device. We have the ability to control the guide wire in multiple directions, including advancement and rotation, as you see here, as the wire is held within this driving system that exists on the robotic arm. All of this can be controlled by this remote station. One of the other advantages of robotic catheterization is our ability to actually manipulate the catheter in 3 dimensions. And we begin to think this way as we start to use robotics in terms of trying to drive through the center of the vessel versus tracking against the wall of the vessel as we advance the catheter and the devices. In the next slide, you'll see some of the movements that exist in the 6 French device. You can see here that it involves 2 points of motion, a curvilinear change at the distal end, and you can see how we're actually changing the shape into a reverse headhunter, a long multi-purpose catheter, something resembling a right coronary, as we have multiple controls in these 2 bending sites. The concept with the 6 French is different than with the 9 French coaxial system because of these multiple bend points and also the ability to actually obtain the distal sweep in 360 degrees, as you see in this tabletop demonstration. Here you can see the 3 principal catheters that exist right now from a commercial point of view. The fundamental 9 French catheter, which involves a 6 French intraluminal sheath and a 6 French sheath and a leader catheter. the 6 French device in the middle, which is the one you just saw the animation of, and then the next generation product, which we should see soon, which also involves a movable sheath and the distal leader catheter. This will allow essentially introduction of any type of therapeutic device that will fit through a 7 French sheath. The 9 French allows the equivalent of any 6 French ID delivery. Next. One of the reasons we got interested in robotics was some of the data that came about from really the first generation devices, where the group at Imperial College in London looked at procedure time, number of catheter movements, and vessel access time to accomplish a prescribed number of tasks. And they compared this versus manual technique. And you can see in both of these actions there was a seemingly dramatic difference between robotic task accomplishment and manual task accomplishment for the same models. As we look at the next slide, you'll see another thing, another discovery that came out of their studies here, and that relates to learning curve issues. If you look at group A, B, and C, they consist of a fellow's experience, an attending's experience, and an experienced attending's experience in accomplishing various prescribed catheterization tasks. If you look at the gray column, the one on the left of the 2 columns, you'll see this represents conventional or manual catheterization, as you might expect. As we move from a fellow to the more experienced attendings, the time to accomplish and the task, the success of the task, the overall performance essentially improves with experience, something that we would naturally expect. However, if we look at the performance of robotics, it's almost the same between the inexperienced fellow and the experienced attending, suggesting what I was alluding to before, the potential of robotics to allow us to accomplish tasks with lesser degrees of training. This, we think, is an exciting potential opportunity. Next. So as we look at the next slide, one of the other studies that was done by the group at Imperial College, and this was Celia Riga and Nick Cheshire's group, is they began to look at the actual work done by manual catheterization, and they developed a very unique catheter tip tracking program, which you can see here on this fluoroscopic image of an arching carotid with a bovine left carotid. And you can see the amount of wall hits and the amount of catheter movement against the wall of a vessel during diagnostic catheterization in this patient who had had a previous CABG. Most of us don't really look at this in a meaningful way, but we began to become concerned as we saw this data. And here you can see the same operator in a model doing manual catheterization on the left and robotic catheterization in the same anatomy on the right. And you begin to see what potential might be derived by robotic catheterization and reducing vascular trauma and making our task of going from point A to point B much more efficient. And in the case of treatment of carotid disease, for instance, perhaps reducing the risk of distal embolization. As we look at the next slide and movie, this will show you what the actual catheter room setup is. This is a patient who's actually undergoing carotid angiography, and you can see where the remote station is positioned, a number of observers and so on, both driving and learning from this. And from this remote position now we can pretty much control everything. Of course, there's a nurse in the room managing the patient. And here you can see the demonstration of the robotic images that we monitor. Here's an example of direction of a catheter as we go around the arch. And what I want to point your attention to is the fact that instead of running along the roof of the arch, we're actually bending the catheter to actually stay away from the wall. And we can do this with 2 motions, in this case the leader and then the sheath. Next. Here's some examples of catheterization of a left carotid artery and then a right carotid artery in this patient who obviously is high risk for surgery with a difficult radiopacification, tracheostomy in place, and so on. And the wire is then driven around, and then we can advance the catheter in the sheath and take advantages of changing of these shapes as we go along. Next. And here's an example showing you the quality of angiogram we can get with hand injections. You don't need power injections through the leader catheter. And one of the differences here is if you're doing a carotid procedure, by the time you get to this point, the only thing you have to do is deal with the stenting. One catheter, one wire, one sheath, and you're fully positioned. Next. Next slide, please. And here we're beginning to do our measurements. Again, the leader's been repositioned to a lower position, more optimal for stenting. And we can, of course, look at the contralateral circulation as well, all using the same catheter, wire, and sheath. Next. These devices can use really almost any wire that you're comfortable using, by the way. There's a variety of wires. You can alter the steerability, whatever type of wire you think might be most appropriate. Here's just a stepwise sequential deployment of the stent and dilation all the way to the image on the right. Next slide, please. And as we begin to look at the completion angiogram, again, you can see what it looks like following completion of the procedure. Moving on to other applications, you can see for very complex high radiation dose procedures such as this complex fenestrated graft where you're worrying about putting devices through multiple fenestrations, operators very close to the abdomen and the pelvis subject to a lot of scatter radiation, that there's a potential role, and we have actually used robotics, and in Europe a number of sites have used robotic catheterization for the purpose of positioning these various branch stent grafts, as you see here, using imaging fusion and robotics, the potential to reduce contrast and reduce X-ray dose, particularly to the operator, but hopefully to everybody by reducing procedure time. As we move on, this is my colleague, Dr. Pena, who's actually doing this fenestrated case, and teams can get involved, and there can be a lot of dialogue while you're continuing to work. Following fenestration, as you can see here, stents are placed, placing multiple stents and devices through these fenestrations, and then we finally do completion angiography. On the next slide, as you see here, showing successful performance of the procedure, and then finally 3D reconstructions as we move on to the next slide show what can be done with robotically assisted fenestration. Next. We can move on to the next slide. Now, I mentioned earlier the 6-French device, which we found very helpful for a number of uses. You're going to see a lot more of that from the other speakers. Again, concept of putting a proximal bend and a distal bend. The concepts that are used here are different than manual catheterization. It's not just a question of creating a shaped catheter, because we're driving these catheters through blood vessels, not just using a specific shape to cannulate an ostium and then tracking them over guide wires. As we look at the next slide, and by the way, that 6-French catheter will take coaxial devices for therapy, and this is an example that my colleague Dr. Gandhi did in a patient that had very difficult anatomy and actually failed during a prior chemoembolization because microcatheter advancement was not possible. As we look at the next slide, you begin to see some of the anatomic challenges. As you see here, the iliac artery had a large bend in it. And of course, any of us could get a catheter through this, but as you do, especially in a non-calcified artery, you're going to get restriction on the torqueability of that catheter, that sheath, as a result of straightening out that very large bend. As we look at the next slide, you'll see the celiac anatomy, as you can see here, and the robotic catheterization of the celiac axis, ultimately cannulation of the ostium, and then beginning to drive the guide wire through the vessel. You can use 3D anatomy and other roadmap, or you kind of go back the old-fashioned way, the way we used to catheterize ostia by knowing where the anatomy is. And here you're going to see an example of the celiac anatomy and some of the challenges in getting a catheter distally. And of course, any of us look at this anatomy and say, of course we could do this. I think most of us feel quite comfortable with our manual skills, but we all know that there's failures as well. And so here's an example now of the robotic catheter placement of a wire and how the wire is sort of driven there on the left and now on the right. You'll see the dynamic imaging of our ability to actually drive the wire and shape it the catheter rather, into a distal location. This is not a tracking process. It's actually a driving process over the wire. Next. And now you can see a very distal location, which in this patient with a very large hepatic mass that you can see here. As we move on to the next slide, you'll see the placement of the microcatheter and ultimately primary therapy. And here's the position of the microcatheter and ultimately properly positioned for embolotherapy. Moving on to our next images, we'll be able to see what it looks like following embolization and then following treatment. The interventionalist who did this case had several observations which are demonstrated on the next image to follow, thank you, which you can read for yourself here. The ability to get stable positioning and manipulate the 6-French robotic catheter allowed for a very easy selection of celiac axis. And these catheters are very much more stable than conventional sheaths that we use. The microcatheter placement was facilitated, and the robot catheter potentially reduced procedure time and radiation exposure to the patient, given the fact that it was 2 procedures, and of course improved precision and stability once there has been something we've seen in a lot of different embolization procedures. Moving on to our next image, I just wanted to show you briefly the sort of range of types of experiences we've been using robotics for as we try and explore where it may have a sweet spot for clinical application. And they included a diverse group of complex procedures that you see at the top, as well as various types of angioplasty and stenting. We have made some attempts at using this as a crossing device, and then of course a considerable amount of embolization, including delivery of large devices like Amplatzers and smaller devices like chemoembolization, microembolization. In our next slide, I just want to briefly mention the ROVER registry that you heard about earlier, and this is an attempt to engage users that are involved in the trial in a it had been retrospective, but now is pretty much mostly prospective, multi-center, non-blinded registry. We're collecting a lot of data to try and understand what the impact and clinical applications for robotics might best be used for. Finally, there is a technology roadmap, so what you're going to see today is really a little bit about what exists, but we're looking at techniques of advanced imaging integration and localization. That's both the catheter tracking using 3D imaging to try and get to floorless procedures, and both Hansen and some manufacturers are working on this. The use of simulation with robotics to reduce procedure time, the potential for telemedicine integration, and then more remote control abilities, including microcatheter control, therapy delivery, and contrast injections, which right now are being done manually. We've also implemented, and this is widely available, a mobility option which allows you to move the arm in particular on and off the table, or even in certain situations from room to room. Next. So in summary, I tried to share with you some early clinical evaluation which demonstrates definite value in anecdotal situations. I tried to share a couple of these with you. The next step for us, as you hear more, is to try and look at clinical trials designed with specific endpoints that could possibly create a tipping point to decide about robotics and the value of robotics. We're currently doing a subset analysis on radiation and fluoro time, and we're looking at radiation. We're doing a radiation study through the ROVER registry, looking at those to the operator team and patients. And then finally, looking at success and morbidity related to this device. And at this point, we've had no device-related morbidity in any patient. So thank you very much for your attention, and appreciate the opportunity to share this experience with you.
Well, thank you very much, Dr. Katzen. And I just want to remind our audience, you may type questions or comments into the questions area in the control panel as we go, and we'll try to address as many of those as possible at the end. Our next presenter is Dr. Keith Sterling. Dr. Sterling is Chief of Cardiovascular and Interventional Radiology at Inova Alexandria Hospital in Alexandria, Virginia. He's Associate Professor also at George Washington University. Dr. Sterling has been the principal investigator on numerous research trials involving drugs and innovative devices. In addition, he's been responsible for pioneering cutting-edge therapies in the endovascular space for both embolization and thrombolysis. Thank you for joining us today, Dr. Sterling. I will now turn it over to you.
Great. Thanks, Brian. I totally appreciate the opportunity to talk and be part of this webinar. So I'm going to talk about robotic embolization and basically real-world experiences that we've had with the Hansen Magellan Robotic System. Okay, let me go to the next slide. So when we were trying to make the decision about why we would want to integrate robotics into our interventional radiology practice, I think the first premise was that we know as a practice we wanted to be, we had a philosophy of being involved in cutting-edge, minimally invasive therapies. And we found this to be a new technology that was very exciting. And then we thought about the fact that we had all had complex cases that we did during our career which could involve increased procedure time. There's increased radiation to the patient, to the staff, and to the physicians, especially when you're doing multiple complex procedures during the course of a day or certainly a career. And then there were those cases where multiple catheters and wires were required to either successfully catheterize an artery, or when you've catheterized that artery, to maintain stable position if you're going to deliver therapy, be it embolization or revascularization. And this could be because of tortuosity in the vessel or different vessel angles. In addition, we all realized that there's technical failures that we had with our primary access, and we may need to perform multiple accesses to accomplish our procedure, or even, as Dr. Katzen mentioned, there's cases where you have to bring the patient back and perform a second procedure. And we also realized that with different people and different training programs, all different specialties, there's a lot of discrepancies in training and the skill set of interventional radiologists and even other endovascular physicians. So again, why we wanted to integrate robotics into our practice is to reduce this unpredictability. We wanted to keep our costs down of the equipment going to multiple catheters, wires, and devices sometimes that we'd open, which we were unable to deliver. And then we wanted to reduce any inefficiencies or overruns in our labs and obviously reduce complications. And we knew that we all had cases just like this, where no matter what you did in this uterine fibroid embolization procedure, you just couldn't get your 5 French catheter or any other catheter, despite multiple catheters, or even your microcatheters and wires, to get into this uterine artery when it's typically very easy to do so. And no matter what you did, it was a very complex procedure. In addition, you had these aortic arches, which were very complex aortic arches if you're going to be doing, as in this case, a right carotid artery stenting procedure, where the angles to achieve what you need to get your catheter and then ultimately your stent into the artery could be quite complex. And lastly, we felt, you know, we're very aware that interventional radiologists now who are even busier receive high radiation doses, and radiation exposure is both cumulative and the effects are permanent. We are concerned about radiation-induced cataracts. The SIR has had a mission to look at this among interventional radiologists, and also we're worried about occupational malignancy. And certainly from all these procedures, wearing lead and standing for long periods of time in complex cases, that we'd be at risk for orthopedic complications. So what we did is we worked with our hospital administration and Inova, and we obtained the Magellan Robotic System at the end of October 2014, so just about 6 months ago. We decided to set up a week of training, and it was important for us to get all of our technical staff trained on this, our technologists and nurses. And we have 7 interventional radiologists in our practice, and we wanted many of them to get trained because all of us brought different subspecialties, even within the field of interventional radiology, to the table. And it was important for us to get everybody trained to see where they might use the robotic system for their individual subspecialization. So there's both, as you heard, the 9 French and the 6 French system. There are actually 2 separate trainings for this, and that's why we dedicated the week for this. And we went through the 2 discrete training sessions, which included didactics, lessons for both the physicians and the staff on prepping and draping. And then there's model training, and I'll show you that in a little bit. And then we set up cases at the end of the week to actually do live cases with patients. We learned a variety of troubleshooting tips, as with any new technology. And then Hansen representatives were there during the whole week to sign off on the physicians who completed the training. And so the next part was to figure out, okay, which room are we going to put this in, and how are we going to orient this in our room. And obviously you have to worry about both the robotic arm itself, which is table mounted to the side, usually on the left side of the table from the patient's side, and then there's the workstation that's going to be in the room, and if we're going to achieve many of the benefits, we're going to want to put this away from, obviously, the table in a good place. So this is our room. We've decided to put this in one of our interventional radiology rooms, and here's the robotic system that's actually draped for a patient. You can see that there's your regular monitor system that's on the left, and then there's the one that comes with the Hansen system on the right, and you can use both depending on where you're standing for the procedure. And there's also a monitor system at the workstation. And then this shows with the robotic system set up for one of our procedures, how it looks at the end of the table. And here with the catheter system in place and ready to drive for this fibroid embolization case. And then this is over in the corner of the room, the workstation. And here we're using, for this procedure, we're a step further away from the image intensifier from the flat panel that's on top of the patient, and we're at the end of the table. So even doing this, we're eliminating radiation because there's a table side control that we could use if we so desire. And in our early experience, we decided that this was advantageous, so we weren't taking off our gowns and putting them back on multiple times during the procedure. But then as we got more comfortable, we went over to the workstation, and you could see from this perspective, we have a lead shield wall here. The staff are monitoring everything, that all is okay with the robotic arm and everything's moving as we want to, and the physician is further away from the radiation performing the procedure. And as I mentioned before, sometimes it could take a variety of catheters to get what you need to accomplish for the procedure, and really with the either 9 French system with or without the leader catheter and the 6 French system, you can achieve really any of these shapes, as Dr. Katzen had showed in the earlier presentation. And so here's the flow model that is in place, which you could see is set up to handle a variety of catheterizations on the left, and here we're using the robotic arm from the workstation to basically train, and this we had access to both during the week and after the week of training if we wanted to perfect our techniques, not on live patients. And here you're seeing an image of catheterizing what would look like a right renal and a left renal artery, and then here a superior mesenteric artery, and then as we got more experience with the 6 French system into internal iliac artery branches. And you'll see here I have some examples of fluoroscopic images of driving the robot in the model. Here catheterizing from an ipsilateral approach the internal iliac artery, and you could see we could advance and maintain a stable position if you're going to perform any embolization procedures. In this case, we were trying to simulate. Also going over the aortic bifurcation into the contralateral iliac artery, and really using the robot to turn, twist, and go over the bifurcation. So what is our current status? We've performed both 9 and 6 French cases. Here's our list of cases. Usually the 9 French case, you're going to do revascularization procedures as described here: iliac artery revascularization, carotid artery stenting, mesenteric artery stenting. And then with the 6 French device, we performed usually a variety of embolizations, and one interesting pulmonary artery thrombolysis case that I'll show you in a second. So there's certainly a learning curve, and that's what I think the model is very helpful for, and things that you need to think about when you're using the device. So one, for the 9 French system, if you're performing a lot of iliac revascularization procedures now, or contralateral femoral revascularization procedures, usually you're using 6 French accesses. So with the 9 French system, you're going to need a 9 or 10 French sheath. We use a 9 French sheath. You're going to be using closure devices. And you need to learn when you're going to manipulate both the guide catheter and then the leader catheter and the wire. And that's totally a learning curve that, you know, when do you bend, rotate, and advance. And what we learned is, I think one of the concerns is with using the robotic system is that you would feel that you lose your tactile feel of the vessel. But what you really learn is even when you're using a manual catheterization, this is mostly a visual feel. When you're looking at what you're doing, you're not necessarily always feeling the vessel as you're catheterizing a normal vessel. And certainly with the 6 French, again, the learning curve is when to use the leader catheter and when not to use the leader catheter. We find that we'll frequently not use the leader catheter, and we'll use the 6 French guide to really bend into a lot of the positions we need to get to. We can perform road mapping through the guide catheter with the wire in place, and then we'll figure out when we're using the leader and when we're going to go right to a microcatheter. So I have a few case examples I'll show you from our practice. Here's a 73-year-old woman presented with mid-epigastric pain. She had a history of cholecystectomy in the past, and in her workup she was found to have a 3.5 centimeter visceral artery aneurysm. And again, with her symptoms of abdominal pain, here's her non-contrast CAT scan demonstrating what at the time was felt to be a gastroduodenal artery aneurysm. And here with the 6 French guide in place, really just rotating it using your anatomic landmarks pointed right at the junction for the superior mesenteric and celiac axis, and doing a nice angiogram through that guide catheter, and then using the robotic system to drive right into the superior mesenteric. And as you can see in this case, we're dealing with a replaced common hepatic artery aneurysm. And then we use the leader catheter to go up into the distal portion of the common hepatic artery, perform angiography, and then, as you can see here, really mapping things out, and then performing coil embolization of both the vessel and the aneurysm while maintaining a very stable position with the guide catheter. And this patient went on to a very successful hepatic artery aneurysm embolization. Next is a patient who had a history of pulmonary embolism and presented with a recurrent submassive pulmonary embolism. The patient was treated a couple years earlier with ultrasound-assisted catheter-directed thrombolysis, and what the operators mentioned was that it was really difficult navigating through the right heart, in that it was very big and boggy, probably more chronically, as the patient had a history of chronic pulmonary hypertension. But the plan in this case with this very symptomatic patient was to perform repeat ultrasound-assisted thrombolysis, and you can see here from the CT angiogram the large pulmonary embolism in the right main pulmonary artery, and obviously the indication here being that the RV-LV ratio is so significantly increased with the patient with a significant degree of right heart dysfunction. And here, coming up from the femoral vein approach, driving the robotic arm directly into the right atrium, and then you'll see on the next, really very easily navigating through the right ventricle and into the pulmonary outflow tract. You'll see how easy it is, and these were almost real-time pictures where we were able to drive then directly into the right pulmonary artery to ultimately deliver our therapy and navigate into the branch of the pulmonary artery that we wanted to, and then pull the guide back, and then we could advance our, in this case, Echo's catheter directly into the pulmonary artery, where we're going to perform the procedure and again have that stability of the guide in place. And then this is the 48-hour follow-up CT, which you see resolution of the pulmonary embolism and more normalization of the RV-LV ratio. Next is a uterine fibroid embolization patient. This is a patient who had 2 prior myomectomies, and interestingly enough, one was done robotically assisted a year prior, and the patient was actually referred for our robotic assisted uterine artery embolization procedure. And you can see here large, despite the 2 myomectomy surgeries, large uterine fibroids in the coronal and sagittal MRI. And then I'll take you right through the procedure where very easily using the 6 French system, driving over the aortic bifurcation into the hypogastric artery, where we can do nice arteriography through a hand injection, and you see this nice sized uterine artery. So this seemed like a great case to use the leader catheter to perform our target therapy of the embolization through, which is in fact what we did. So advancing that wire and just navigating that leader catheter in place and having nice flow into the uterine artery, and then performing the embolization. And that's the post-embolization run on the left. and then similarly doing the same thing with the same catheter to treat the right uterine artery and navigating right into the right uterine artery, as you can see we're doing here, and then with the leader catheter in place, performing a successful embolization, and this is the final aortogram which demonstrated occlusion of both uterine arteries. So again, one of the reasons to use this is catheter stability, and as you can see here with the TACE case, a very complex celiac artery origin to perform this TACE procedure. And then with the 6 French system, you can really straighten things out, still have flow, and have a stable catheter position to perform the embolization. And then as Dr. Katzen described before, the direct catheterization of the vessel instead of scraping along the wall. And you can see here with the aortic arch, you really hate to scrape along the wall of the aortic arch in this place, as opposed to just navigating the catheter directly into the left carotid artery to perform both the arteriography and then ultimately the stenting procedure. So I want to get to the big issue of radiation reduction, which I think is something that you'll be hearing more and more about. And this is actually courtesy of Dr. Sandeep Rao in El Paso, Texas, who performed 10 TACE procedures, and he used the RaySafe I2 active dosimetry system to look at intraprocedural radiation exposure to both the operator, the technologist, the additional support staff, and at the control side, at the bedside where the table side controls are. And this is an example of the RaySafe. There's all these dosimeters which give you direct feedback during the procedure of what the radiation exposure is to. And what they found is in these 10 cases, the radiation dose to the operator significantly decreased over time. And you'll see they work from the independent workstation for the last 7 cases, where you can see the radiation dose to the physician is markedly reduced down to a 5.2 on that last case. And then if you look at the bedside control, what you're getting, and this is when you're doing your typical procedure, you're standing by the patient, and in their 10 cases, the average radiation was 220 millirem, but to the operator on these cases working from the remote station, it was an average of 8.1, and as I said before, this is when working from the remote workstation, how significantly reduced the radiation exposure is. So in summary, obviously you can see there's many potential roles for use of the catheter robotic system. There's a potential for increased predictability of doing the procedure, increased stabilization, decreased catheter exchanges in the complex cases, and decreased radiation exposure for the operators. So thank you very much, and Brian, I'll turn it back to you.
All right, well, thank you very much, Dr. Sterling. Another reminder for the audience, you may type questions or comments into the questions area in the control panel. We'll address as many of those as possible at the end of the presentation. Our final presenter is Dr. Sandeep Bagla. Dr. Bagla is an interventional radiologist at Inova Alexandria Hospital in Alexandria, Virginia. He's actively involved in conducting and publishing clinical research on a variety of topics related to interventional radiology, including pancreatic cancer, pulmonary embolism, and prostatic artery embolization, or PAE. Dr. Bagla was lead investigator on the first published study from a U.S. cohort on PAE for the treatment of benign prostatic hyperplasia. Thank you for joining us today, Dr. Bagla, and I'll turn it over to you.
Brian, thank you very much for the invitation. I'm excited to speak about the role of robotics in prostatic artery embolization. And so a couple things I'm going to cover here. First is just review the literature for PAE and describe a little bit about who's a candidate for the procedure, then focus on what the challenges are with the procedure, because I think that's the main obstacle that we face with PAE. And then the transition of the Magellan robot into our current practice with PAE, and then what those actual advantages are over the traditional method, and I'll show some case examples. So in terms of who's a candidate, there's really a few ways to break this down. The first is looking at what does the data support in terms of which patients to treat, who are poor traditional urologic candidates, and then let's talk about who's not really a candidate at all for PAE. And so the data, when we look at a review article from 2014, this was published in CVIR, and it reviewed all the studies done up until mid last year. And as you'll see on the next slide, they looked at 562 studies through a PubMed database study. They ended up narrowing it down to 9 articles in which they reviewed 706 patients that were actually included in the analysis. There was some possible overlap of data from European studies, And there were no randomized control trials at that point published or studies longer than 2 years. All patients had moderate to severe symptoms in terms of their prostate enlargement or BPH. And the mean age of the patient in these studies is, as you would expect, in the mid to late 60s to early 70s. And what they found when they took all the data together and they pulled it all together, they found out that although these patients started in a moderate to severe category, as you can see here in the dark blue line, this is an IPSS score, which is the severity of symptoms a man faces from their prostate enlargement. And you can see that it reduced by more than 50% in the first month after the procedure, or PAE, and was durable to at least 12 months and then out to 36 months. Their quality of life, which is on a different scale of 0 to 6, did also improve by 50% or more, and this is also durable out to 36 months. So besides this really impressive clinical improvement, they also found that there was a decrease in prostate volume, PSA decreased, and importantly, there was no deterioration in sexual function, and they concluded that the overall benefit of PAE is very positive at 12 months, and the procedure does seem safe. Now, subsequent to this, there were 2 randomized controlled trials that were published and presented at a national meeting. The first is this study that was published in Radiology. It was a Chinese study. It was a randomized control study, looked at 114 patients in which half of the patients were randomized to get TURP, which is the traditional transurethral resection of the prostate or Roto-Rooter type procedure. And this procedure, which is performed through the urethra, as most people may know, is associated with a significant complication rate, anywhere from 5 to 15%, in terms of things like incontinence, impotence, bleeding, etc. And other complications, such as retrograde ejaculation, occur in up to 75% of patients. And so in this study, they wanted to randomize patients to TURP or PAE, and they looked at mid-sized prostate patients, which are 50 to 80 grams in size, and they followed them for 2 years. And what they found is both sets of patients had significant improvement in symptoms that did not differ. The PAE group, however, did have twice the failure rate compared to TURP, and that's important because that difference in failure rate was really related to the technical success of the procedure, which speaks to the challenge. Carnaval presented his data from Brazil at the 2014 American Urologic Association meeting, in which they did 15 patients in each arm when they compared TURP and PAE. And they found also both arms demonstrated significant improvement. Although there were less complications with PAE, there was a better improvement in terms of quality of life and flow rates associated with the TURP arm compared with PAE. And you'll see here that in the Gauss study, both red and blue, PAE and TURP, from 0 months to 2 years, on both left and right. Left is the clinical score of IPSS. How do people do? And you can see they both have significant clinical improvement, and there's no difference at 24 months. And in their study, there was no difference in flow rates, as you can see on the right, at 2 years. In the Carnaval study, you'll see that they both improved in terms of symptom improvement. However, there was a greater symptom improvement in the TURP arm than PAE. And on the subsequent slide, you'll see that the flow rate did improve greater in the TURP arm than the PAE group, although the PAE group did return to a normalized flow rate, which is about 15 cc's per second in an adult male. And so further, other studies have also demonstrated improved quality of life, and I won't really touch much on this, but a quality of life study that was published by Carnaval also demonstrated that in patients who were catheter dependent, in 90% of patients you were able to remove their catheter in patients who had BPH and complete bladder outlet obstruction. They did have one complication, and that also speaks to the technical challenge of the procedure, and that was an area of bladder ischemia in which the catheter was probably placed in an area where the embolic material was then delivered into the vesicle or intravascular artery going to the bladder. So are there limitations to other therapies and give us opportunities with PAE? Well, with large glands, as you can see here on the left, or in the central area of small prostate, or with a big median lobe on the right, there are different complications associated with those procedures, and those complications are things that limit the ability of traditional procedures like TURP, microwave, laser, and allow PAE to come to the forefront as a relatively low-risk procedure, however technically challenging to perform. So for PAE, does size really matter? And you'll see here on the left with a large prostatic artery, here in the middle with an average size, and on the right with a small prostatic artery. Ironically, the large prostatic artery on the left has the most tortuous course. So even though it may accommodate a catheter easiest in terms of its size, the tortuosity does limit the ability for the interventionalist to actually catheterize and secure a distal catheter position for embolization. So there are technical challenges with each size, but in terms of clinically, as you'll see here on the next slide, whether it's a large volume prostate, as you'll see here on the left, or in the center, whether it's mid-sized prostates or as we've presented recently here at ISET in Florida at Dr. Katzen's meeting on the right, small-sized prostates, mid-sized prostates, and large prostates all do the same. They all demonstrate significant clinical improvement, and we also presented this data at the SIR meeting just last month. And so are there challenges with PAE, and why is this not so widely adopted? Well, I just mentioned earlier how tortuous the arteries can be to navigate, and I think that's really one of the most primary challenges of the procedure. The anatomy in elderly men does distort and misdirect pre-shaped catheters, or as we call, pre-robotic catheters. There are small distal target arteries which require proximal support, which sometimes proximal catheters like 5-French catheters cannot offer. Acutely angled origins, which I'll get into. The origin of the prostatic artery is often acutely angled. Then there's some issues with actually recognizing what is the correct prostatic artery. And then the last is a safety issue. Well, the cases can take a long time if they're not consistent and performed in a reproducible manner, and this can lead to high radiation doses not just to the operator but to the patient alike. So is there really a role for robotics at all? And I'll get into this here with a few examples and what those challenges are. So in terms of limitations here, you can see here on the left, this is a fairly straightforward ipsilateral iliac artery selection in which we used a reverse curve catheter like a Simmons 2 catheter to do our selection. And then where the green arrow is a very small prostatic artery, and I know that may be challenging to place a microcatheter in because of its size, the angle by which it comes off the anterior division of the hypogastric artery is not particularly challenging, and the actual anterior division, which here is paralleled by a red line, is fairly straight. And so placing a catheter into this artery and angling the tip of that catheter medially is actually fairly easy to do in a patient like this. However, on the next slide here, you'll see that we have patients in which we use either a reverse curve catheter like we did on the previous, or we use a Waltman loop, in which interventionalists are familiar with using a Cobra catheter and then trying to direct or angle that catheter tip medially. Unfortunately, in a patient here, not in this patient in particular, because of common iliac or external iliac, common iliac artery tortuosity, torquing that Waltman loop medially can be very challenging, and no matter how much you torque the catheter, the distal tip still wants to point laterally, and that can limit our ability to select a medially oriented vessel. And so on the next slide, we're also limited by things like a steep aortic bifurcation, and here in which the angle is about 15 to 18 degrees. Getting a catheter up and over this bifurcation may not be so challenging, but having the catheter stay there while you perform distal embolization or subselective catheterization, that can be more challenging, in which the proximal catheter may back out. On the subsequent slide here, you'll see ipsilateral hypogastric artery angulation can offer the same challenge, in which we may place a catheter not just via Waltman loop, but directly into that hypogastric artery, and that angulation can also limit our proximal support. Here is what I was talking about in terms of acutely angled origin. This angle, as you can see here on the slide on the left with the red arrow, is pointing to a vesicoprostatic trunk. So it gives origin to the vesical artery, which goes to the bladder superiorly, and then that tortuous artery, which extends inferiorly, is the proper prostatic artery. That acute angle is very challenging to negotiate a microwire, a microcatheter, unless you have good proximal support. And not only that, support which actually angles medially, so it allows proper selection of that vessel. That angle is very commonly seen in patients in which there's a vesicoprostatic origin. In patients in which the prostatic artery arises from other origins, that's not often seen, but in this particular example it is. On the right slide here, you can see a similar example where the vesicoprostatic trunk, the straight vessel which arises off that red arrow, is a branch that goes anterior to the bladder, where that curved arrow that goes inferiorly is the prostatic artery. And unless you have good proximal support or proximal angulation, then it's very difficult to put that microcatheter distally into the prostatic artery. On the subsequent slide here, you'll see that this is a case in which we failed selective catheterization. On the left picture, we failed selective catheterization because we could not get our Waltman loop angled medially and subsequently get our microcatheter into that first tortuous artery that makes a complete reverse curve and then goes down. Subsequent to that, we brought the patient back, and you can see here, this is actually a robotic 6-French guide catheter, which is placed, and the tip is angled just to the origin. And on the slide on the picture on the right, you'll see the catheter extends just distal to that radiopaque marker and is seated right at the origin of that really tortuous artery. So then on the subsequent slide, you'll see we were able to place our microcatheter distally here, and it was placed using the robotic catheter as support and angulation, so we could basically pick off the origin of that vessel. and then advance our microcatheter distally, and you can see on the image on the right how hypervascular and large this prostatic gland is. So despite having a massive prostate, it still was very challenging, and the robotic catheter in this case we used very successfully in a patient who we failed initially in the pre-robotic era, if you will, for us. Similarly here in that case I showed with ipsilateral hypogastric artery angulation, how do we get over this? You'll see on the next slide, we can take that 6 French catheter and perform angulation by angling the proximal articulation point away from the hypogastric artery origin, and then using our distal tip, angulating it medially, and then seating it very well into the hypogastric artery, and then driving that catheter down into the anterior division, as you'll see, and then performing prostatic artery embolization from there. So not having to perform a Waltman loop and then manipulating this catheter, it's fairly straightforward, and you can see, without getting too confusing here with some terminology, the actual arc that is performed on the distal tip of that catheter, or what I like to refer to as the tightness of the curve, the ability to curve the distal tip of that catheter, is so acute that it allows you to actually perform a selective catheterization of a vessel that's completely 180 degrees from the origin of the parent vessel. And you can see here from these videos that advancing that catheter, and in this case we're advancing it over a glide wire without the leader catheter, just the 6 French catheter alone, over the leader catheter into that hypogastric artery very successfully into the anterior division, and then subsequently be able to perform, as you'll see on the next slide, our prostatic artery embolization. And in this case, in which, if we can go back just one slide here, we advanced our catheter in. That middle picture is just to demonstrate how tortuous this artery actually is, and how well this 6 French guiding catheter, or robotic catheter, can be advanced over that wire without significant difficulty. And I think that's important, because when performing prostatic artery embolization, what I always tell our techs is the contralateral side is often not as difficult as the ipsilateral side, and this has really reduced our time in ipsilateral prostatic artery embolization. So on the next slide here, you'll see this is exactly what I went by, that tight radius. If you look here, before we perform our selective catheterization, this is a complete 180-degree selection of that hypogastric artery. But on the right in the video here, the cine image, you can see that distal tip, we basically curve on itself to then select and then perform a hand injection through that guiding catheter. And it gives us great imaging of the hypogastric artery and subsequent branching. And we don't even need to use a power injector at this point to do our subsequent injections. On the next slide, you'll see this is another example of us driving that catheter into the hypogastric artery distally without an issue, both on the ipsilateral side, and then you'll see on the image on the right, or the video on the right, on the contralateral side here, we're driving that catheter all the way into the obturator artery. So clearly it can be driven very distally in both examples. This is even without the leader catheter. I think initially it might be nice to use, but we found that actually with distal embolization for prostatic, with distal target embolization for PAE, we've been very successful without it. It's actually streamlined our workflow. Here's an example of where you need to angulate the distal tip of the catheter to bring your catheter tip to the origin of the prostatic artery, and then perform an easier selective catheterization. Where the red arrow is clearly where the distal tip is of the robotic catheter, but the anterior division, as you can see right at the origin of that very small prostatic artery, is where the green arrow is. And what we can do here is just use our either bedside control or tableside control, or our remote workstation, and articulate that distal tip, and then use our microcatheter, and it's seated now right at the origin of that vessel, or at the anterior division, and it allows us a less frustrating experience and not having to select that superior gluteal artery repeatedly, and allow us to advance our microcatheter into that prostatic artery. On the subsequent slide, you'll see another example of this. Here we wanted to bring our distal catheter, 6 French robotic catheter, into that anterior division where it bifurcates here into, say, a gluteal and pudendal artery. And we brought our 6 French catheter, as you'll see here, all the way down to that bifurcation of prostatic artery and pudendal artery, and then subsequently brought our microcatheter into the prostatic artery and performed our embolization. So it can not only be used in the hypogastric artery and the anterior division, but here we brought it down even into the internal pudendal artery to then perform our subsequent embolization. As you'll see here on the next slide, this is another good example of distal angulation. We use our microcatheter here after getting that catheter in the hypogastric artery on the left. We use our catheter here, angulated again into the anterior division, You can see how small that vessel is, probably perhaps 5 or 6 millimeters, and able to bring that catheter into that vessel without a problem. On the subsequent slide here is an example of us bringing that catheter, or the 6-French catheter, up to a trifurcation point. So we brought it up to where the inferior vesical artery then bifurcates into a prostatic artery, which you can see extending all the way to the left of that leftward image. And once we brought it to that bifurcation or trifurcation point, in this example, we're easily able to bring our microcatheter down distally, as you can see on the image on the right. And that's a great example of prostatic artery perfusion, as you'll see, and how distal we take that microcatheter basically into the gland before we perform our embolization. So why is proximal support so important? Well, with small target arteries, it's obviously important to have proximal support, because as you're advancing your microcatheter, it's easy for a 5-French catheter or even an Ansel sheath or a proximal sheath to back out. But with this robotic catheter, it takes on a fixed position. So that proximal support is very important and does not back out. In an easier selective case like this, where the vessels are not very tortuous, and you can see they all sort of take obtuse angles, proximal support may not be as important. But unfortunately, this is not the typical case in an elderly male. On the next slide, this is actually 3 different videos where I wanted to show you the example of what that distal articulation does. You can see here on the video all the way on the left, as we're just articulating the distal tip, we're directing that distal tip towards the prostatic artery. In the video in the middle, once we direct that catheter tip medially, now we do a hand injection, and you'll see with that hand injection we now can opacify 3 different vessels. One going laterally, one going medially, and then in the middle that really tortuous double S-shaped vessel of the prostatic artery. And here in the video on the right, without even using the microwire, because of that proximal support, that microcatheter is able to be advanced into that prostatic artery with very good proximal support, maintaining antegrade flow, and in a very tortuous artery. And so this is a perfect example of how that distal navigational ability really allows us to select a really difficult, normally difficult vessel to select. Here's an example of that pushability. So if we need to get that catheter all the way down into the gland, you need that proximal support in order to get that distal. And this is just to show how distal we take that microcatheter before we perform PAE. On the next slide, you'll see here. So this is the next slide where we can demonstrate, even when we leave that 6-French catheter way back here, I mean, this is in the anterior division of the hypogastric artery, that microcatheter can still be advanced very distally, as you can see here on the slide on the right, into that prostatic artery and perform our PAE. So the support is still there even with a proximal placement, and I think that's really important, where with a 5-French catheter, as most people know, when you're performing advanced embolization of the pelvis, especially up and over the bifurcation, that catheter can easily back out on you if you're trying to advance your microcatheter very distally. So last thing I want to talk about really quickly is this hypogastric artery knuckle. So we go to the next slide here. This is basically where you see here this orange circle. In elderly men, the hypogastric artery, as it bifurcates, forms this knuckle, or where it travels from a posterior location to an anterior location and distorts your 5-French catheter. So although your C2 catheter, Robert's catheter, or any angled catheter you want to direct medially towards that green arrow where the prostatic artery is, when you bring it through this knuckle, it tends to direct laterally. And unfortunately, despite any torquing that you do to the catheter, that knuckle in the hypogastric artery can malform your catheter. And you can see that here as evidenced by those white arrows here on the right. So on the next slide, you'll see the normal solution is to take a 6-French sheath, which can be fairly painful, however rigid, and use a buddy wire, as you'll see here with the blue arrows. And in this case, we use a shorty wire to straighten out that sheath and try and then redirect our microcatheter into the prostatic artery. That's very challenging, and unfortunately that does not work very well, because now you have to go to a bigger sheath, and because you have to allow it to accommodate both your buddy wire and microcatheter, and the two do not torque very well together. So as you'll see here, the solution with the robotic catheter is once you bring it through, as you can here, and here's our target here with the red arrow, you can see our robotic catheter going through the knuckle here. Once we bring it through, now we can angulate that distal tip however we want, and it will fix our position. And in this case, we angled it to the origin of that vesicoprostatic trunk, and it allows us to then select that target vessel without redirecting a traditional catheter into the wrong vessel. And so here, we want to get into this white line or prostatic artery, and this can demonstrate how we can get all the way down to the origin through the knuckle without a problem. On the next slide, Again, same thing to show here, medial angulation. Once we bring it past the knuckle, you can see the difference between the left slide and the right slide is that the angle of the catheter here, we just directed it medially, and that's really important. And so one more example here to show distal support. You can see here in the video on the left is a cine image from a hand injection, and that very first branch is a very short trunk or a vesicoprostatic trunk, and this is another example of why you need that proximal support because of that severe acute angulation. As you can see here on the right, it's that first branch and then the double S-shaped curved vessel, and that is really important and critical here. So we can move on here. Yep, and this last couple of shots, just to show that exactly that last case, we were able to take that glide wire into that vessel, bring the robotic catheter down to the origin, and then you can see here on the slide on the right, bring our microcatheter into that prostatic artery and subsequently perform our PAE very successfully. And so this really has come to really prove a real advantage for us in terms of our PAE procedures. You know, in terms of the data for PAE, my personal feeling, there are issues to work out in terms of reimbursement in future prospective clinical trials, but PAE definitely is here to stay. The data is very supportive of doing the procedure, and I think that's really important. The biggest issue with the procedure besides clinical trials and prospective clinical trials will be the technical challenge associated with the procedure, and I think that's going to limit the widespread adoption. This is where the Magellan Robotic System, I think, really shines. It's really offering us the potential to improve the procedure in terms of ease, consistency, reducing our radiation dose because we can actually stand 4 feet or more from the patient's pelvis. And then in terms of marketability, there's an undeniable fact that interventional radiologists have been limited in their ability to market their procedures and because of the way they get referrals from other physicians. And I think that this system can offer us a real advantage in terms of marketability. And so besides just making our procedures consistent and allowing us to take advantage of the robot in terms of difficult procedures in which we wish we had the robot and we didn't before, these advantages have really come to fruition for us, and we use it now on every case that we can in terms of PAE, and it's really, like I said, improved both our ease and consistency. And so, in conclusion, that's how I'd like to end. And Brian, again, thank you for the invitation to speak to this audience.
All right. Well, we have all 3 of our speakers here for our Q&A period. I'll ask them to come off mute now. I'm going to direct the first question to Dr. Katzen. Dr. Katzen, there's a question here about tactile feedback. Dr. Sterling touched on this a little bit, but one of the main concerns for interventionalists is in going to robotic navigation, potentially to give up tactile feedback with the hands. Dr. Katzen, if you're still with us there, I wonder if you can address that, what your experience has been.
Sure, thank you, Brian. I think this is probably one of the common questions that people have when considering robotic catheterization. I think all of us have grown up on developing unique tactile feedback. And one of the things we found is that what we interpret as tactile feedback, when you actually start to critically look at it, is actually a very large proportion of visual feedback. Specifically, if you see a guide wire blunt, you may or may not actually feel a guide wire bump up against the wall, but you'll see it deflect and we respond to it. So I think that there's a surprising amount of what we interpret as tactile feedback that's actually visual in nature. Secondly, you have to understand what's creating the tactile feedback, and that's basically, as I think Keith mentioned earlier, Dr. Sterling, that we're basically dragging, sliding, whatever word you want to use, a catheter along a guide wire that's generally out against the wall of a vessel. And particularly when we're probing around an ostium, trying to pick off an ostium, what we're doing is basically dragging or pushing a catheter trying to find an ostium. So I think the value of tactile feedback, certainly based on current manual skills, is really critical based on the current foundation that we have. But I think there's also some both clinical and lab evidence that it may be more traumatic than we think.
Thanks, Dr. Katzen. Our next question relates, I'm going to direct this to Dr. Sterling, and it's a question about the different catheters that are offered, the 6 French versus the 9 French catheter. Dr. Sterling, because you've had some extensive experience with both of those catheters, can you talk about what your considerations are when choosing to use one versus the other for a particular case?
Sure. I think that most of our cases have actually ended up being embolization cases, and for those cases we're using the 6 French catheter system. And as I said earlier, we're using it more often than not without the leader because you get, as Dr. Bagla just showed in his prostate talk, you get your guide catheter and you can position it in exactly the direction you want to and then advance your microcatheter with a lot less difficulty. So we're using the 6 French system mostly for embolization, visceral embolizations, and basically driving to where we want to get our therapy, if you will, be it the Echoes catheter for the pulmonary embolism or our microcatheter for the embolization procedure. And then I think the 9 French system we're using for a lot of endovascular reconstruction uses, so stenting and angioplasty and such, because I think that you need to have that larger device as the main guide, and then you'll use the leader catheter with the wire to actually get through the lesion. So we're using that, and I think in certain anatomies like carotid arteries and endovascular aneurysm repair, that 9 French device is going to be your device of choice.
Okay, great. Thank you very much. And maybe last question here for Dr. Bagla. Dr. Bagla, in terms of the staff, have you what has been your experience with the learning curve for the staff and the training process they've gone through? How have they adopted the setup and utilization of the robotic system?
Yeah, I think like with any new technology, there's always a learning curve in terms of the staff learning anything, and I think that they welcomed it. One, I think they were, from an emotional standpoint, they were excited to obviously adopt a new technology that would be exciting and something new. As far as the actual technical aspects of it, I think it's very straightforward, and they had no real issues. I think just like anything, learning how to drape the actual robot, learning how to unwrap the devices and set them up, probably added about anywhere from 5 to 10 minutes in terms of case time. That's about it in terms of their setup. We don't really see it. It's pretty streamlined, and we don't, as you know from our experience, we don't really rely on having anyone else there because the staff has become fairly autopilot for the device itself.
Okay, thank you very much, Dr. Bagla. Dr. Katzen, anything to add on your end on that topic at all, just about overall integration into the institution or with your staff?
I think the learning curve for the staff has been very good, fairly simple to do. I think a lot of the training involves, for physicians, involves preparation of the device. In the end, much of that goes to our support staff and so on. I think it's become relatively easy if we wanted to do something on the fly, let's say, in terms of preparation, to be able to do that. So I think that's all quite manageable.
Okay. I think those are all the questions that we have for now. So I guess at this point we're going to bring the meeting to a close. I did want to thank our presenters, Dr. Katzen, Dr. Sterling, Dr. Bagla, very much for your time. Thank our participants for joining. And to our attendees, you will be receiving an email link with a link to the recording of the event. It will be posted on our website, www.hansenmedical.com, and also emailed out to you by the end of the week. And this concludes today's webinar. I want to thank you again for attending.